Thank you so much. And I have to apologize for the poor quality, at least of my picture. I'm in the middle of other conference as well. However, I'm glad to share our data and discussions on the actionable findings. What we did in the past 5 years, we switched from panel sequencing to whole exome and whole genome sequencing. And in this course, you may anticipate that we don't not only find basically the genes of interest, which are potentially causative for the rare diseases or for familiar cancer syndromes, but we find other genes as well, or variants in other genes, which may be disease causing. And there's a major discussion in the community in different countries and different sites, whether we should share these data, what are the preconditions to share the data, and what types of data we actually are going to share. So based on this, there was or is an international discussion how we should call these findings, and there's a definition of basically different terms, what also always means very similar or identical things like actionable findings, actionable genes, secondary findings, opportunistic screening, and so on. In Germany, we call them Zusatzbefunde or Nebenbefunde. And basically, these are genetic findings which are not associated with a primary clinical diagnosis, but rather have significant implication for clinical management in terms of disease prevention or even in terms of treatment. I show you one example. This is a pedigree of a small child which was referred to us, which had neuroblastoma with 3 years, unfortunately already. And there was a discussion, could this be familiar? What could be the cause? And basically, it was not unexpected that we found the FOX2B gene mutated in this child. And of course, the question was, is this de novo or is this familiar? The parents were afraid that the sisters and the brother of this small child would also be a carrier of the mutation and thus have a high risk of neuroblastoma. But in the course of the discussion, we did also find the BRCA mutation as well. Now, the major discussion is BRCA mutation. Should we share the information with the child, with the parents, and so on? So the point is that we decided together with an ethical board in Tübingen that we should share the data, and particularly as a mother or father could be a mutation carrier as well. And it turned out that the mother was a mutation carrier as well. And now we have, of course, prophylactic and predictive measurements in terms of, preventing breast cancer and ovarian cancer. And it turns out extending the family analysis that in the family of the mother, there were also already very unfortunately, the sister died very early in terms of breast cancer, and the mother had also breast cancer as well. So it fits to the pedigree analysis, but very frequently we do not find these obvious family information in the pedigrees. So this is actionable findings. This is additional findings in addition to the neuroblastoma situation what we had. Now, there are a couple of publications in this regard, all very different, I have to say, so very difficult to compare how frequently we could find or should find these actionable findings in certain cohorts. So let's look at the second line. In Nijmegen in 2018, they detected 1 in 33 to have such an actionable findings, but this was just a limited gene number. In a different study from Snyder et al. In 2019, they defined like 17% had actionable findings. In Qatar, very surprisingly, I'm not sure if this is true, they found only 0.6%. Now, I mentioned already that we have a huge tool of experience in tubing in this regard. And just in these 3.5 years, from October 2017 to February 21, we sequenced a total of nearly 13,000 exomes genomes. And in this cohort, we had basically 6% of the patient who had also actionable variants in the so-called ACMG 59 list. And I'm coming to the ACMG list a bit later in my talk. And a total of 3% of the patient wanted to have this information back. So we transmitted close to 200 patients the information. And because this one, you can see on the right-hand side that most of the actionable findings come from the cancer field, CHEK2, BRCA2, and PALP2, and so on. These were clearly breast cancer genes, however, and this is a list on the left-hand side because this is a cardiology meeting here. You may anticipate that we have quite a couple of patients also with mutations predisposing to cardiomyopathy, long QT syndrome, and arthropathies. Again, these were not the primary diagnosis, but rather secondary findings in the patient. And of course, this needs special attentions of the cardiologists as well. Now, today, we are working on the American College of Medical Genetics list, the ACMG list, the version 3.0, which just appeared this year or was published this year. Before, we had a list of 59 genes. Now we have 73 genes. There are a lot of recommendations from ACMG on different types, what we should test, what we should not test, and so on. And I'm showing you a couple of these issues also from Europe, where you may anticipate that it's not as easy. So we have different types of actionability. One in terms of ACMG, which is immediate, predictive, and preventive therapeutic implications. Then there are type 2 actionable genes, which are diseases without a clear option to prevent the disease. And then there are type 3, which are life decision planning. In Switzerland, they have also type 1, 2, 3. However, in type 2, they, for instance, classify also the cardiomyopathy genes in it, what we have in Germany in type 1. And then in the life decision planning, they have diseases like retinitis pigmentosa, neurodegenerative diseases, what in Germany we have rather in type 2. So it's very difficult really to compare between the different countries. And we are in Germany rather now following these 5 categories and focusing right now on category 1, which is these ACMG lists. We have a population frequency roughly of 5 to 6%. As I mentioned before, we will also work on pharmacogenomics later. We are also working in parallel actually on the low risk disease genes, which are the polygenic risk scores. And I give one slide at the end of my talk. We are not working on the family planning issue. However, I would like to mention that in America, they make a strong recommendation for this. So it may change in Europe also in the next few years to say, well, this mother has, for instance, a mutation in the DMD gene. She will not be affected by her own. However, if she gets a child, a boy actually, which has a mutation, he may then later on develop the disease as well. So that is basically life decision planning. That's not what we are doing right now in Germany. I'm showing you here a list that even in the States, different companies, Myriad, MyCode, and the ACMG and so on, and they have different recommendations for the different selections of the genes. So that is not always clear even if we define category 1 to be looked at it. And that was the reason, and they have also a clear grading system, what I think is very necessary, which is based on, giving points to severity, likelihood, efficacy, burden, and so on. So I think that is a very important step to categorize these ACMG genes. And we in Germany, of course, we are also dealing with these issues. First of all, and I think everyone can anticipate that we have to have a global informed consent on the patient, that the patient wants to know, and if he doesn't want to know about these findings, that of course he should not be informed, and that we should not look at actionable genes at all, so we should blind them in our analysis. However, this needs some counseling before, and also clear indication what these actionable genes might mean for them. Overall, in our experience, we have that more than 90% of all the patients we have in our house would like to be informed about the actionable findings. But I show you here also one patient who really crossed out basically everything. Does he don't want to be informed and so on. He also don't want to inform doctors or family members at all, not only about actual findings, but also about the right diagnosis. That makes, of course, a very difficult situation sometimes. And please remember the pedigree I showed you before on the child with a neuroblastoma with a BRCA2 mutation and the actual findings, where probably several of these sisters and aunts and so on would love to have some the information whether they are on risk for breast cancer or not. But we have to accept these, and we have to follow also the rules what the patients tell us. I mentioned before that we are working in Germany also as a network on these actionable genes, and I showed you the list of the people who are right now actively working on the gene list, as we call it, and would in particularly mentioned here Eric Schulze-Barr and Jörg Schmidtke, who are really doing a lot of work on the cardio genes in general. So thank you guys all that you do your additional work on all this. And we have this scoring system as well, as I mentioned before. And based on this, we are looking at different genes, whether they should be added or not to the actionable genes list, to the German ones, I have to say, which differs a bit to the American one. And I would like to encourage all of you either to participate in the GeneAct list, so just send me an email, or even to say, well, there may be a gene which I would love to see, or where I would consider this would be an actionable genes. We have preventive decisions afterwards. So also you could suggest certain genes, and we in the consortium will look at the different genes and give them a scoring and add or not, add this or not. As I mentioned before, there are different rules in the different countries, and this is one very extensive one from Australia. And you can see here when they ask the geneticist whether they should transmit incidental findings, what types of it, and so on. You can see on the right and the left-hand side, they will never tell the carrier status or say maybe we would do this, though that was in our hands the actionable findings list category 5, pharmacogenomics as well. And interestingly, the people differentiate here between whether they perform whole exome, whole genome sequencing, then they will not inform about pharmacogenomics, but in panel sequencing they would do. I personally don't really understand these different decisions, and I was surprised that even they do transmit, and this is basically in the middle of this slide, the adult untreatable ones, they would even inform to quite a significant level to the patients. I think we have a very open discussion in Germany that we should not transmit a carriership for Parkinson's disease, Alzheimer's disease, Huntington's, and so on, if not appropriately counseled before. Now, there's quite a long-term ongoing study in America, what they call the Geisinger healthcare system. They implemented these actionable genes many years ago and have quite a good interest in this or good experience in this. They offer it to any patients which are enrolled in their clinics. And you can see on top that there are already more than 250,000 people enrolled in this, and they are treating at the same time the patients in the hospitals in this regard. And you know that in the American system, usually it's everything has to be paid, but in this case, the testing is for free for the members of the Geisinger medical care, because they can really see the advantage in preventing diseases before they even occur first. In Germany, we have the situation that there are many of the institutes, or the majority of the Human Genetics Institute offers these genetic testing. Usually it's the ACMG list, as I mentioned before, but there are also extended ACMG lists, and some others use just a limited number of genes in it, so it's not harmonized across all centers. But when you see on the right-hand side, the majority of the experience of the actionable genes and transmitting the data is really very good, and very few exceptions in this. There are two ways of reporting, either to write it in the diagnostic report directly or to provide a separate report. The diagnostic report is, for instance, a patient who comes with Marfan syndrome and you would like to see the call genes. On the other hand, you could then in a separate report mention the BRCA2 or BRCA1 mutation. That would be separated. We in Tübingen do it always in a separate report, because that may be some special information which goes to, to a different doctor, different type of doctors, and you would not sometimes not like to share all the genetic information with each one. So we do it separately. However, there's no clear guidance for this, and that really depends on the experience in the different labs. And then or you inform always, or you inform occasionally, and so always after informed consent. We have even one institute which says, well, I don't care if the patient decided he doesn't want to be informed, I will always inform him, because I think life-threatening genetic conditions like BRCA1 and 2 has to be informed. Otherwise, I have medical I could face some consequences of legal issues. So that is an open discussion and not really decided yet in Germany. So the implementation would be, we recommend to have a separate report. We offer genetic counseling to the patient also before and after. However, you as a medical doctor, of course, you can say, well, you have a genetic test, and whether the patient would like to have additional findings, you can do this. You can counsel the patient on this. And if the patient afterwards would like to have some more precise information, of course, you could recommend to human genetics institutes or private practices as well. You have to know that the genes may not be completely covered in all the tests, so there's no responsibility to have it completely covered. There's quite some uncertainty about the legislation today, about our Gendiagnostikgesetz, what we have in Germany, because there is not written anything about additional findings. And discussing with these people, this is really an open question. And please consider that the number of the actionable genes, as I mentioned before, may always be modified. And each medical doctor, as I suggested, may recommend new genes which we should integrate. I'll show you one case report, and I apologize because it's from our own practice. This one is in German. This was a child born in 2018, has developmental delay and cognition deficits, and has also generalized epilepsy. Here we showed that the patient had a clear mutation in the HNRMPU gene, so that fits also to the phenotype. That was okay, but in addition, and this is surrounded in red, we find these additional findings, and it was very exceptional in this case that this small child had 3 additional findings. One was in JAK2, it's another breast cancer gene. Same applied, as I mentioned, to the neuroblastoma child as before. In this case, the mother was checked and was having the JAK2 mutation afterwards. The other mutation was in hemochromatosis. This doesn't affect the child at all, probably not even the parents, but as a frequency is so frequent in the general population, we inform the parents as well. But the third indication, or the third actionable finding, was a very interesting one also for the child. It was a mutation in CYP2C19. And this one is one which metabolized in particularly anti-epileptica. And you see the entire list of anti-epileptica which may not really work in this child. And indeed, talking to the parents, they told us that already they are trying to change to the fourth different anti-epilepticum because nothing worked. And then we could immediately tell them, okay, we know the reason why it doesn't work, and do not use these treatment lists or the drug list, but rather switch to a different compound. And indeed they switched, and the child immediately responded to the other anti-epilepticum. So that was quite helpful, although it does not change the developmental delay in this child. However, we could at least help a bit. I mentioned already that with moving to the whole genome part, we can also look at polygenic risks, so combined risks of very minor implementation of each single variant, but in a combination of, let's say, hundreds or sometimes thousands of small risk variants, we can get sometimes very high risks, even in the range of 40–50%. So that is the same range as having a BRCA2 mutation and developing breast cancer. There are many different polygenic risk scores, also for breast cancer, but also for diabetes, heart diseases, and so on. And we are implementing them in my lab. So we implemented breast cancer, just did, last week the diabetes, and we are changing now, or implementing now, discussing with the clinicians how to implement the polygenic risk score for the heart diseases as well. So that will be a challenge to each one of us because it's not monogenic, but polygenic disease, but will be very interesting. And then we will have a population where we have quite a significant proportion in the range of 10% or even more having a higher risk of developing a certain disease. And this could really prevent in terms of lifestyle medications sometimes when you think of statins, but also of nutrition, and so preventing the disease. And I think many patients, many persons at risk would like to know about these risks as well. What we have to do, we have to do a certain type of teaching. Sometimes we are quite surprised, like with this neurologist, he asked the patient if she would like to know the actionable findings the patients wanted to know. We got clearly crossed, yes, I would like to be informed, and so on. But despite this, the neurologist did not inform the patient because he said, well, I don't want to inform them. I don't know how to do it. It's a breast cancer gene. I'm just a neurologist, but that is okay. However, these neurologists did not recommend it, even this woman, for genetic counseling, and that is not okay. So you can question whether the patient was really informed in if she would like to be informed on the breast cancer list or not. So I think we all have the responsibility to clearly define what we would like to know or not. Now, this will be my last slide. What we should not forget, that is a lot of things still going on. We don't really know about the age at onset, progression, and so on, about genetic risks. So particularly on the late manifested order diseases, that we have a different risks with the same mutation in families where we have several affectors versus families who have no affected family members. So that the risk may be different, and we are still working on it. There's no clear answer. We have sex differences. We have very strong population differences. So everything what we implement is true for the, let's say, Middle European population, but when we have patients, for instance, from the Turkish ancestry, these polygenic risk scores might be different, but also the penetrance of other things may be different. So we are working on this as well, and we are working on the severity and so on. Need national cohorts for this, and as I mentioned before, data are crucial for all this, so we need a central accessible database, and we are working at the German level as well. There's a new initiative of the German Ministry of Health, what they call Genome DE, and in the frame of this network, we will implement it and roll out all over Germany. With this, I would like to thank you for your patience, and I'm happy to take questions. Thank you.
Yes, Professor Riess, thank you very much for this very interesting talk, which shows that we need to work interdisciplinary for sure, and also that considering the whole world, it's still very different how this is managed, comparing US to Europe and especially Germany, to how to report these findings. There is one question from the audience. I read it. Would you report a BRCA1 or BRCA2 pathogenic variant if a boy, a girl was tested by single exome sequencing? If yes, would you report immediately or when age of 18 is reached, since we don't offer predictive testing before adulthood?
So the point is that we do not report this variant to a child, basically, but sometimes the parents insist and would like to be informed. And as I mentioned before, we had an ethical board working on this, and we decided that we will share this information to the parents. There is this small gap: when should the child be informed about this variants? And usually these variants are really not clinically relevant in children. So basically the information should be given in adulthood, latest 5 years before the earliest manifestation in the pedigree. So it could be, that we have a mother or an aunt of this boy or girl you are talking about manifesting already at the age of 22 or 21, then one may even consider talking about this at the age of 17 in girls and boys. It doesn't really has an effect in BRCA1 and 2. However, there are mutations like in CDH1, which is manifesting gastric cancer and breast cancer, for instance, and this may manifest even in young adulthood. And we have seen, very unfortunately, boys and girls at the age of 15 already manifesting with gastric cancer at this age, and that they are very hard to detect. So it sometimes really depends also on the mutation on the gene when we recommend testing.
Okay, thank you for this answer. Very clear. Another question: do you validate actionable genetic findings with a second patient blood sample? Or maybe the question is, always a second blood sample for all genetic testing?
Absolutely. They are so relevant for the family and for managing. Yes, we are doing it in a separate sample, and this is not being charged for, so we do it for free. Yeah.
And from Joko Kühnisch also, can you please comment on the polygenic risk scores for heart disease you currently implement?
Yeah, so basically there are a couple of different polygenic risk scores. We are currently evaluating which one may be the best meaning for the for the German population. Most of them are coming from the British population, and we are quite close to them. There is quite a discussion that even with a high polygenic risk score, even if hypertension and cholesterol and so is still normal, statins may even help in preventing developing the disease. I'm not sure about this, I have to say, but there are papers on this. Of course, it will not be in our hands, not the polygenic risk score on its own. As I mentioned before, the body mass index, hypertension, and the cholesterol and so will be included in the PS score as well. So it will be a combined score. And then we recommend nutrition and healthcare projects and so on this. Would this answer your question?
Yeah.
Or are there
I
more?
think there's a lot to do in genetic counseling. If we
Absolutely, yeah. I think there's a huge demand.
The more we need to counsel and explain to the clinicians and patients. So
and again, I mean, we are not doing this on our own, so that it goes together with internal medicine, always with a specialist, and usually we are working for a year or so before we decide how to implement what PRS score we say. And so, there was one thing, we are looking particularly on the PRS for the 10 years risk, because many of them are for term risk evaluated, because we think it's maybe easier also for the patient and the doctor to say, okay, within of 10 years could be developed, you have a 30% chance to get cardiovascular disease. It's more feasible for the patient to accept 10 years risk instead of until the age of 80, you may have a risk of,
Okay, I think thank you very much for your very excellent talk, and we have to move on.
Pleasure.
And
thank you.